Hi, class. This is going to be our last recording on the chapter of bone tissue. We're going to focus on bone disorders and fractures, bone diseases, and how they're treated and how they can be prevented in this recording. So first, let's talk about what orthopedics is. Orthopedics is going to be a branch of medicine that's going to associate itself with bones, joints, and muscles. The name itself, the name origins, implies treating skeletal deformalities in children. Think of pediatrics for children, ortho for the bone, an older root word for bone. So orthopedics is a pretty broad field. We can have the design of artificial joints and limbs, treatment of athletic injuries. I'm willing to bet that probably 10 or 15% of you have had a torn ACL or torn ligament in your knee that was treated while you were a high school athlete. A lot of us have some experience with orthopedics. Stress fractures are super common. It's going to be a break caused by some kind of trauma to the bone. And when we think of a stress fracture, I'm not referring to, the painful shin splints associated that cross-country runners get because they've been running too much. I'm referring to some kind of a physical injury. So you hit a bone in some way, or you fall in some way to break a bone. We could also have pathological fractures. These are going to be fractures related to a disease state. The two most common are going to be osteoporosis or bone cancers. These are typically going to be indicated when a mild bump or bang that normally would be totally fine breaks a bone. So if we have a mild stress break a bone, that's usually a red flag that there's some kind of a disease state, either osteoporosis or bone cancer. For instance, if you look at little kids that have normal bone density, they fall on the ground all the time. They slip and fall on the ice, on the sidewalk constantly, and they bounce and get back up again. But if you look at geriatric individuals, particularly geriatric females that have osteoporosis, if they fall and slip on the ice, lots of times that results in those individuals having broken hips. As we look at fractures that can be accumulated in our bones, we can classify those fractures based on the direction of the fracture line, whether or not there's a break in the skin, or how many pieces have formed during that fracturing process. So, first, let's talk about the best possible fracture you could have, a non-displaced fracture. If we look at a non-displaced fracture, you can see there's a crack right there on the bone, but the bone fragments themselves are still in the correct position. So this is the best possible kind of fracture. It's the most easily treatable kind of fracture. We also could have displaced fractures. And as we look at this displaced fracture, this is a pretty severe fracture right here. The bone fragments themselves have physically shifted from each other. So we can focus on the positioning of the fragments, non-displaced versus displaced. We also could talk about the number of fragments. This is a fracture that results in two pieces. If we have a fracture that results in more than two pieces, we call it a commuted fracture. Sometimes this is referred to as a shattering or a fragmentation of the bones. We also could have a green stick fracture. A green stick fracture is a partial fracture to the bone, and these are particularly common in young children. I have a 3-year-old boy who actually had a green stick fracture earlier, about 4 months ago. These green stick fractures are relatively benign, heal relatively quickly, and then, the one that gives me the EBGBs, but you love to see it in Hollywood films, it's the compound fracture, the broken bone sticking out of the skin. So as I'm looking at this image up here, we have not a compound. This is a contained fracture, but over here, as I'm looking at this fracture on the screen, I'm willing to bet this fragment right here, that sharp point of the tibia, has been puncturing the skin. I'd be willing to bet this is a compound fracture if we were looking at an actual photograph of it. Regardless of what kind of fracture you have, there's the same generic process for healing all fractures. First, we're going to have a blood clot or a hematoma form. This blood clot, after we snap the bone or fracture the bone, the periosteum is going to help to contain the blood that oozes out from all of those capillaries that are broken. As those capillaries bleed out, the blood coagulates and forms a hematoma. That hematoma is then going to form what is known as a soft callus. And the soft callus is going to have a lot of fibrocartilage within it. So we go from a blood clot to fibrocartilage. Notice how the blood clot bulged out, and now the fibrocartilage is bulging outward at the point that the bone was broken. Now we'll have a hard callus form. And during this process, the fibrocartilage is going to be penetrated, impregnated, and assimilated by osteoblasts, bone-building cells that are going to build a thick, bony collar of compact bone tissue, and will build up some spongy bone tissue in the center. And then finally, we'll have a little bit of bone remodeling. The compact bone tissue is further reinforced around the perimeter of the bone, and the spongy bone tissue in the center will be reassimilated by osteoclasts to open up space for more marrow within the marrow cavity. Note how ultimately at the end, typically 4 to 6 weeks later, we have a bone which is thicker and stronger at the point of fracture than it was initially. This is one of the reasons why very few people will break a bone in the same spot twice. This is also a very important reason why it's important to have our bones set so that they heal correctly the first time. Because if those bones don't get into the correct position, we have to break the bone and reset it and then have it re-heal. And breaking the bone the second time is going to be very painful because the bone is now thicker, harder, and stronger, and it's going to be that much more difficult to break. So to keep the bones in the correct positions, we're going to reduce the fracture. We can have a closed reduction if the bone fragments are out of place, and this is going to involve just a physical manipulation. So I have a physical therapist for a spouse. My wife is amazing. She does closed reductions occasionally on her patients, where she'll pull, yank, tug, and touch and feel the site of breakage to make it so that the bone fragments get back into the correct position, and then sets the bone and puts the cast on. Or we can have an open reduction. When we have an open reduction, we're going to have screws and plates. We're going to have some kind of surgery and mechanical hardware be used to realign the bone fragments. Lots of times we'll have casts. For those of us that are a little bit older, a lot of times these casts were plaster or fiberglass based. But one of the newer things that we're seeing right now is removable casts or soft casts that have a lot of Velcro on them, so you can take them off, bathe, and have some hygiene associated with that part of the body that's cast, and then put the Velcro back on and have protection. They're really nice. Anyone who's had the traditional plaster casts can tell you just how nasty it is when those old plaster casts are taken off. A lot of times we're going to have traction to help treat the fracture. Fractures of the femur in particular are rather dangerous. There's a lot of strong bone tissue around the femur, and that are strong muscular tissue around the femur. And that strong muscular tissue, which is around the femur, can cause the femur bone fragments to bend and shift and move out of position. So to help prevent that from happening, we will apply mechanical force to the appendage, which is known as traction. And this is going to keep the bone fragments aligned correctly by overriding the force of the thigh muscles. In older adults who have more self-control, they typically don't need to have the traction, and instead they'll just have some surgical pins installed to help keep the bone fragments in place. Most fractures will heal in 4 to 6 weeks. If it takes more than 2 months, more than 8 weeks to heal that bone fracture, there can be electrical treatment of that fracture. So there could be electrical stimulation, referred to as E-stim. And E-stim can partially suppress the effects of parathyroid hormone at the site of the bone fracture where the bone is healing. Recall, parathyroid hormone is a hormone that upregulates blood calcium concentrations or upregulates osteoclast activity. And when we're healing from a fracture, we want more osteoblast activity, and we want to downregulate the osteoclast activity. Another common disease of individuals that have fractured bones is osteoporosis. As we look at osteoporosis, the word osteo means bone. Porosis refers to the porous nature of the bone. And here on the left-hand side, we can see healthy spongy bone tissue or trabecular bone tissue. And on the right-hand side, we can see some bone tissue, some spongy bone tissue associated with osteoporosis. The spongy bone tissue is going to be most affected by osteoporosis because it is so metabolically active. And when somebody has osteoporosis, they have constant, consistent low blood calcium levels. And they are going to be constantly pulling calcium from their skeletal system and dumping it into the bloodstream to compensate, to maintain homeostasis. And this is a good thing. We need calcium for our nervous system and our muscular systems to work appropriately. The downside is that while they may have a moving muscles and a functioning brain, their bones start to become brittle and prone to fracture as they lose the spongy bone tissue from their bones. Something else that occurs is kyphosis. Kyphosis, or the widow's hump, is typically going to be known as a deformity of the spine due to some kind of vertebral bone loss. It's typically going to go hand in hand with osteoporosis. So as we look at this process, as somebody loses spongy bone tissue from their vertebral column is prone to deforming. They could have kyphosis, or the widow's hump. They could have lordosis, sometimes referred to as swayback, or they could have scoliosis develop, where the spine bends starts to deform laterally as opposed to anterior and posterior. These processes, these disorders of the spine, can make it more difficult to move. And as they have a harder time standing up straight, that makes it difficult for them to breathe in and out, which can increase the amounts of pneumonia they experience, or it can increase the amount of thromboses they experience, or blood clotting that they experience. You may come down to the basement, Ben, but I'm not done with my recording yet. Osteoporosis is oftentimes going to be directly related to the sex hormones in the body. In particular, males and females will have low levels of estrogen. Even males will have this estrogen in their bodies that helps to maintain bone density. Estrogen inhibits osteoclast activity. More than any other demographic, postmenopausal white women are at high risk of osteoporosis. Once they become postmenopausal, the ovaries stop producing estrogen. The adrenal glands still produce very low levels of estrogen, but because they've lost most of the estrogen from their bodies, they have a dramatic increase in osteoclast activity. Generally speaking, starting at about the age of 35, many white women will start to lose bone mass. This can be due to decreasing estrogen levels, or also due to decreasing physical activity and dietary factors. Typically by the age of 70, most of these postmenopausal white women are going to have lost 30% of their total skeletal system mass. So when we look at risk factors for osteoporosis, race, age, gender, smoking, diabetes, mellitus, dietary factors, sun exposure, these are all things that can influence the risk factors or the ability of osteoporosis to progress. Something else that causes osteoporosis to progress is body fat concentrations. Particularly in young female athletes, I'm thinking of ballerinas, gymnasts, Ben, please be quiet, I'm making a recording. Or individuals that do long distance running, oftentimes will have low body fat. And as the amount of adipose tissue in the body declines, the background estrogen released by those adipose tissues will go down as well. That causes the individual to stop ovulating and have even less estrogen being secreted in their body, ultimately upregulating osteoclast activity. Having a period, having a menstrual cycle is a good and healthy thing for young women because it is associated with elevated estrogen and higher bone density. So, how do you treat osteoporosis? Well, if it's all about the estrogen, why not just give the person some more estrogen, have estrogen replacement therapy? This is going to slow the bone reabsorption rate or downregulate osteoclast activity. The downside is that as you increase estrogen concentrations in individuals that are postmenopausal, you have an increase in breast cancer rates, and you also have an increase of stroke and heart disease. So it's kind of, a catch-22. Do you want to decrease? Do you want to have elevated osteoporosis, or do you want to have elevated breast cancer? There's some other drugs, other methods like Fosamax or Aston-L. These are drugs that are specifically designed to focus on and destroy osteoclasts, the bone-dissolving cells, and they are not a hormonal-based drug. We also could use, or particularly an estrogen-based drug. We also could use parathyroid home supplements. parathyroid hormone is going to promote or increase bone density. In particular, it's been found that individuals that start taking this medication will have an increase in bone density of about 10% in a year. The downside of parathyroid hormone supplementation is that can increase the risk of bone cancer. So there's not these treatments aren't very good. Once you have osteoporosis, there's not much you can do that won't have a lot of negative side effects. So what's the very best thing you could do? You can prevent osteoporosis from happening. Get a lot of calcium, get a lot of sunshine, and have a lot of physical activity when you're young and healthy. Maximize the amount of calcium you store in your skeleton when you're able to store the calcium in your skeleton so that you have enough in reserve to make it through your senior years and not develop that osteoporosis. Oh, one more moment, then I'm almost done. So, as we age, the senescence of our skeletal system or the malfunctioning of our skeletal system can have both osteopenia and osteoporosis. Osteopenia is loss of bone mass, just generally speaking, and this is a normal generic process. A specific kind of osteopenia is the osteoporosis, which we've talked about in detail already. I'll just recap briefly. It starts typically about the age of 30 when osteoblast activity goes down. After the age of 40, women are going to have an accelerated rate of bone loss. And if somebody has osteoporosis, their bones become very brittle. And they also are going to have decreased protein synthesis by the osteoblast or less collagen in their bone extracellular matrix, which makes it difficult for the inorganic component to crystallize because there are fewer nucleation sites present in the bone's extracellular matrix. And that's all we have for our bone tissue chapter on bone tissue. If you have any questions, please shoot me an email or feel free to swing by my office hours. Happy studies.